We send a mass email to the to all the patients in our network.
Oh, great.
And then they're posted on the website too, like on our website as well as the YouTube channel. So they can, can view them if they're in their leisure. Which I'll be sending them, you know, when they want to go on CGM to go watch.
Patients in our network.
Oh, great.
We are live.
Okay.
All right, so I was just waiting for this to come up and okay, so, and this is normal, by the way. So one of my people that I follow, he has like 1.2 million followers. And every time he opens the session, like 5 minutes, he's talking about how difficult to get on and all that stuff. So I'm now, okay. So, good evening. This is United Medical ACO. My name is Kamal Erkan. I'm the chairman for the ACO, and this is our wellness webinar, Wednesday wellness webinar. And we are here with Amy Wilcoxon and Celeste Milliner, and we'll talk about our diabetes, topic of diabetes and the remote monitoring, right? Today is going to be the remote monitoring. So I'm going to go ahead and open our PowerPoint so that everyone can see what we are discussing. And just before we start, actually, I do want to also introduce Donna Dunkel, who is not able to join us today because she's on vacation. Dr. Ripo Handal, who was with us 2 weeks ago, he's our program director. Everyone knows already Amy, and Tim is our physical therapist, and Jackie is our social worker for the program. So this is our goal is to make sure that we are making all the knowledge and different parts of the diabetes available to our patients. And that's our main goal. And from different specialties, we have different guests available. And we do twice a month. We do these events twice a month, and hopefully we can continue doing them on a regular basis. So, Amy, would you like to introduce yourself first and then Celeste?
So my name is Amy Wilcoxon. I'm a dietitian and diabetes educator with the United Medical ACO Diabetes Program. And as Kamal said, here for our Wednesday webinar to talk about all aspects of diabetes. And we're so happy to have Celeste with us. Celeste, if you would like to introduce yourself.
Sure. Hi, I am Celeste Milliner. I have been a certified diabetes educator for about 16 years now and worked originally in the pediatric hospital setting, and then began working out in the community with adults with type 1 and type 2 diabetes also. So I'm thrilled to be here.
All right, thank you. And Celeste, what I'll do is I'll give you the remote control from here. And I think now you are in charge.
Okay, so this evening I'd like to discuss with you continuous glucose monitoring, or as short, we call it CGM. Well, it's not advancing.
It says that it's waiting for you. Maybe there may be a slight delay. So
there we go. So are we good?
Well, is there something on the screen that says you may need to accept the control?
Okay.
It just, what I see here is it says waiting for you to control the screen. Maybe if you want to click on the arrow.
I don't see that. Okay. We'll go ahead and get started. So our agenda for this evening, with regards to continuous glucose monitoring, will include the history of CGM, the role of CGM in diabetes management, the burden of this disease, and I'm sure I will be preaching to the choir there, the importance of CGM, and then lastly, we will touch on insurance coverage.
All right,
So as far as history of CGM, CGM first became available in about 1997. So to put that in perspective for you, excuse me, not 1997, about 2007. So it's only been around for about 15 years. But to give you a little bit of perspective on that, blood glucose monitoring or finger sticks have really only been available since the late 80s. So, you know, we're slowly evolving to get up to great technology that will reduce the burden for those people living with diabetes. So that's sort of the history. You know, prior to the 1980s, patients managed their diabetes simply by dipping the urine to see how much glucose was in the urine. That's sort of an old measurement. So that's what they did previously, and then they would adjust insulin according to a broad range. So for instance, a urine sample may show that you have a glucose level anywhere between 200 and 500. And it's very, very difficult to intensely manage diabetes without the precision that we have now with CGM. CGM became available in approximately 2007. And they have just continued to evolve. If you look at the history of CGM, you will see innovation and change that has developed almost annually since. So there's a huge demand for this as we look towards having what some people may refer to as an artificial pancreas or another solution for managing diabetes. Having an accurate CGM is going to be imperative. So that's a little bit of touching on the why. I'm sure those that are listening would agree that it's not fun to stick your fingers. You know, you go to the doctors and the doctor says, I want you to check your blood sugar before your meals. And you know what? I'd like a couple of blood sugars 2 hours after meals. And the difficulty is A, the strips are expensive. B, it's uncomfortable. And C, it just doesn't seem to happen. And it's then therefore very difficult for your healthcare provider to manage your diabetes without the information necessary. So the role in the management is just really multifaceted. So when you think of CGM, many of you may not realize there are alarms for highs and lows that are available with continuous glucose monitoring. Having the information at your fingertips, do you like what I did there? Is really, really essential in managing your diabetes. So when I think of safety, I like to think of the features of a CGM that helps to keep your patients, you or your children or your loved ones safe in managing their diabetes intensively. So you have alarms that will sound for high and low blood sugars that you can customize. Another safety feature is directional arrows. So when you check your blood sugar and you see a number of 100, most people are doing a happy dance. That's fantastic. But if you are 100 and you've checked by your finger stick, you don't really have much more information other than what your number was a minute ago when you checked it. Is it going up? Is it going down? What does that really look like? When you have CGM, they have directional arrows that will give you an indication of whether or not your blood sugar is nice and steady, if it is rising quickly, or falling quickly. And this is essential. If we think back to the example I just gave you of a blood sugar of 100, and we're doing the happy dance, if your blood sugar is 100 and it's Friday night and you're leaving work and you have an hour and a half long commute and heavy beach traffic and you're dropping quickly, that provides you with a lot more information to keep you safe. If you want to look at another example, if your blood sugar is 95, again, we're quite pleased. That's a tremendous number. But if you're 95 and you're going to bed and your blood sugar is dropping quickly, you may want to have a few carbohydrates to prevent a potentially severe low blood sugar episode in your sleep. So another example to the opposite degree is it will also keep you safe, particularly those with type 1 diabetes. It will give you an indication of when your blood sugars are high and perhaps not responding well to insulin to help prevent DKA or diabetes ketoacidosis. It's going to give you that information so that you can more quickly respond to your blood sugar numbers and correct those situations. So, I mentioned assist in intensively managed diabetes. So most providers now are giving insulin for every meal that you consume. Having a CGM is very, very helpful in aggressively managing diabetes. One of the potential risks of managing your diabetes intensively or with every meal is the risk for low blood sugar. Our goal is to keep you preferably between 70 and 180 after your meals. But to do so requires a lot of work. And the more information we have or your healthcare provider has, the better we're able to do that. So where CGM comes in to help you do this is it can help you determine the timing of your insulin. So I'm sure you've heard healthcare providers say, get your insulin in prior to your meal. Try to get that insulin in 15 minutes before you eat. And, I know that everybody does the best they can, but using CGM, you will quickly see the difference of pre-meal dosing and what your blood sugar does when you give your insulin halfway through your meal or at the end of the meal. You will see that, wow, my healthcare provider really does have a point. I had no idea my blood sugar was rising that high after my meals. And again, like I had mentioned, it will also help to prevent some lows. It fills in the gaps for your healthcare provider. This graph, I think, is very, very telling. Those red dots that we'll notice on there are the finger sticks that you do when you check. So this person is doing a fantastic job checking 5 times a day. If you look at those numbers, and I apologize, I didn't realize they were in the European measurement of millimoles, but that the blue shaded area is our target zone. So this patient looks like they're having tremendous blood sugars when they do their finger sticks, probably somewhere between 100 and maybe 130. But what they're missing, because they're checking only 5 times a day, are those excursions, those high blood sugars, as well as the low blood sugars. So a CGM will provide you up to 288 readings in a day. With using a CGM, even if you're checking 12 times a day, there's a ton of information that is missed. And looking at this graph will really help you manage your diabetes better. So for instance, if I look at the third hump on this graph, it's about dinner time, and clearly that insulin needs to be in sooner than it was to prevent such a rise in blood sugar. So that's kind of completing the picture. Your healthcare provider will be able to go through and, you know, look at all of that information and make adjustments that are truly, truly customized to your needs. So that is sort of filling in the gaps. The greatest challenge in managing a patient's diabetes is not getting enough info. Even if you are the rock star, stellar model patient and you're checking 12 times a day, there is information that we don't have that can help you. And a CGM will really be a tremendous tool to fill in those blanks for your healthcare provider. My word, what greater benefit than no more finger sticks? I will give a caveat. Every continuous glucose monitor company will tell you if your symptoms don't manage or don't match how you're feeling with that number, they will tell you to always do a finger stick for confirmation and go based on that finger stick. Those instances are very few and far between, but for the two most popular continuous glucose monitoring systems, no finger sticks are required. And with the other two, and we'll touch on the different types, the other two systems, there is a reduction in finger sticks. And again, it will fill in the gap for you. With CGM, it does give you the ability to have less hypoglycemia. It gives you the ability to respond before you have a bad low blood sugar. It will reduce diabetes emergencies by giving you this information for you to respond to. And I, at the risk of sounding like a car salesman, I can't guarantee the system alone will do that, but it will give you the tools so that you can reduce your diabetes emergencies. And it will help you to reduce any hospitalizations due to diabetes that you may have. So I don't know if you notice WIFM. So this is like a big big analogy of what's in it for me. So when I think about continuous glucose monitoring systems, I like to think about what is this going to mean for my patient? And, you know, in all instances, our patients are first and foremost. So I want to discuss now the benefits that a person utilizing CGM will receive. So we did talk a little bit about timing. Using CGM will help you perfect timing as far as, you know, getting that insulin in to prevent those excursions. It will also help you and your healthcare provider compare A1C versus time in range. So I'm going to touch on this just a brief little bit on A1C versus time in range. So most patients will go to their healthcare provider and their doctor will say, your hemoglobin A1C is about 7%. That's fantastic. That's where we want you to be. However, you can have an average hemoglobin A1C that is down in range, but you can still have huge excursions. Your blood sugar can still vary from 400 down to 30, but that average is what gives you an A1C of 7%, if that makes sense. So stick with me here. So years ago, when hemoglobin A1Cs were basically all we had to provide us an indication of a patient's likelihood of developing complications related to their diabetes, that's what we used. You know, we knew what our goal was. But as continuous glucose monitoring has evolved, we now know that time in range is even more important than a hemoglobin A1C. So let's go back to that scenario of having blood sugars that vary between 400 and perhaps 30, averaging out, let's give you an average of about 200. That time that you spend in range is a very, very good indicator of your likelihood of developing complications. The excursions, those rises in blood sugar and those falls are what we now know to be correlated with small vessel damage due to your diabetes. So it's tremendously important that we have more time spent in range and less time spent with those hills and valleys and blood sugar excursions. So what else is in it for you? Safety. That's probably the number 2 reason that most patients choose to go on CGM. Number 1 would probably be no finger sticks. And number 2 is it does give you that peace of mind that if my blood sugar drops at night, that my CGM will alarm and let me know. Some CGM systems even have an ability for other people to follow your numbers real time, and they will also get an alarm. So for instance, if you are traveling and you're in a hotel room and your blood sugar is low, your wife may also be able to get that alarm to give you a call and say, hey, honey, it's time for you to drink a little bit of juice. You're a little bit low. So safety is, I would imagine, in the adult population, the number 2 reason why people like to go on continuous glucose monitoring. Also remember those directional arrows that really fill in that picture for you. It helps you to interact with your care team. The 4 CGM systems that are out and available in the public right now, your healthcare provider can have a near instant download of where your blood sugars are. So if you call and say, my word, I have had the stomach flu, I've been throwing up, my numbers aren't good, I don't know what to do. Do I go to the ER? Your healthcare provider can then pull up your CGM readings and see how you were responding to insulin and help you make adjustments remotely. Did I say no finger sticks? In most systems, there are absolutely, at a minimum, a reduction of finger sticks. In 2 of the systems, no finger sticks are required. So as far as features, we've talked about directional arrows. I think that's even more important than that individual number is. When I look at a number and see my CGM shows a blood sugar of 84, those arrows really help me to complete my timeline. I like to know, when did I last eat? When did I last get insulin? And what direction is my blood sugar going? And once I have that timeline completed, it helps me therefore to figure out, how do I manage this? Do I need to intervene and make adjustments? Or is my blood sugar responding as I would hope it would? And then lastly, continuous glucose monitoring systems have the ability to integrate with insulin pumps, with smart pens that are now becoming more and more widespread, or just simply as a standalone unit for patients that are on injections alone. I think, so these are the systems. So this is the Abbott Freestyle Libre. All CGM systems have 3 components. There is a sensor, and that typically is underneath the skin. The white spot here for the Abbott, the round circular, yep, that is the transmitter, and the transmitter's job is to send the blood sugar from the from the sensor to the receiver, to the patient. In some instances, it may be a freestanding separate receiver that you would carry, such as this. In other instances, the receiver may actually be like a cell phone. So 3 components: sensor, transmitter, and receiver. This is the Abbott Freestyle Libre. You can see with this, there is a number, there are directional arrows, there are trend graphs that are customizable. So you can look at the last 3 hours, the last 6 hours, the last 12 hours. With this system, it is imperative that you wand over top of that transmitter to get a number and to get directional arrows and alarms. So it is somewhat interactive in that respect. But again, as I said, no finger sticks required. The next system is the Dexcom G6. This is where I referred to a receiver could be either a separate device that you carry or a smartphone. In this instance, you can see both on display here. Information can also be sent to smartwatches. Again, the same 3 components: sensor, transmitter, and the receiver. Directional arrows with this system, if you look at the circle where the number is displayed, there is a little pointy end, and that lets you know that this person's blood sugar seems to be fairly stable. This system, again, also does not require any finger sticks. It does have alarms for highs, lows, and it does have the share and follow capabilities. Our next system is Medtronic. So Medtronic has a CGM. They have one that is freestanding as well as one that is integrated specifically with the Medtronic insulin pump. Again, 3 components: sensor, transmitter, and receiver. So for Medtronic, if you're utilizing this with an insulin pump, typically that insulin pump will act as a receiver also, or the information can be sent to a smartphone. You also see here the number, the directional arrow. So all of those components seem to be very similar. This system will only integrate with the Medtronic insulin pump, none of the other insulin pumps that are available. And this system does require a reduced number of finger sticks. And lastly is the Eversense. And I'm bringing this CGM up just for a discussion. I'm sure if you are out on blogs looking at diabetes, you may see some mention of Eversense. Eversense is a continuous glucose monitoring system that has been available for about 2 years. The difference with this CGM system is the sensor is a long-term system, a long-term sensor. So it is implanted in a minor office procedure. It is good for up to 90 days. Right now, the challenges seem to be some insurance coverage, and you may have a problem or difficulty finding a physician that is certified to do the procedure. So if this is a system that meets your needs, the company, you can reach out to the company and they can direct you to a certified physician that is in your area that may be able to assist you. This system
who does that? Like, can the primary care do that? Can they be?
Yeah, so a primary care, a nurse practitioner or PA, or an endocrinologist or primary care. And it really is, it's a very quick, minor procedure that's done just with a little bit of numbing medicine. The system is approved for placement in the arm. And, I have a great deal of familiarity with that CGM system. It probably takes about half an hour start to finish. It takes longer to get the arm prepped and place that sensor in there. So I think the last thing that I wanted to discuss was insurance.
I'm sorry, I did kind of divert from the PowerPoint just to see what this looks like. This picture here.
Oh, yeah, great. Thank you.
No problem. And I didn't know this, so I was just searching on my iPad first, and then I just emailed to myself.
Yeah,
So this
thank
is
you for doing that. So that is the sensor. It is about the size of 2 Tic Tacs end to end. The diameter is about the same width, and then the length looks like 2 Tic Tacs. So there's a tiny, tiny little incision made on the arm, and it's just tunneled right underneath the skin. One of the differentiating features with this system is that the transmitter can be taken on and off. That's the black, yep, that piece, with a piece of adhesive without losing your sensor. And the other differentiating feature with this system is that the transmitter is the only transmitter available that provides on-body vibration to notify the patients of high or low blood sugars.
Wow.
I think I mentioned 90 days, up to 90 days of wear. So, it's a nice option for a lot of patients. When I look at where we have progressed from in 16 years, going from a blood glucose monitor that took, a drop of blood that was this big from your finger, that was sort of accurate, now to CGM. We just have so much more to offer our patients. And it's a tremendous discussion to have with your healthcare provider. The American Diabetes Association now recognizes CGM as standard of care. So truly to have insurance cover a continuous glucose monitoring system, most companies, including Medicare, want to see that you are on 3 or more mealtime insulin shots per day. They want to see that you are checking your blood sugar 4 times per day. They want to see a diagnosis of diabetes, whether that is type 1 or type 2. And then for Medicare requirements, they want to see that you are making frequent adjustments. So for instance, if your blood sugar is 50 and you're getting ready to eat dinner, are you going to take your whole dose, or are you going to correct for that low blood sugar? So while people say, no, my doctor makes my adjustments, every day you're making adjustments in your diabetes management. So those are the 4 criteria that are kind of universally standard in getting CGM approved.
So I have, I have a maybe question and a little bit maybe feedback. So I think our patients should be managing the PowerPoint. So then before you say next slide, then you have to kind of really pay attention. It does help you to learn more.
Yes.
So now when I have to do this, I have to pay more attention. And I know it sounds like if I'm joking, but I'm not. Like this happened last time with Dr. Handal. I'm like, oh, I didn't know that. Like, I'm like, how did that happen? And how did I miss? Because we hear it so casually, so many times, so many different places, diabetes, glucose, and it's like almost like part of life, but it's no one really maybe understands or knows very well until they have to deal with. And I think the learning, because when we do the bariatric patients, we do the A1C first, and in some cases, when the A1C is high, we have to do the fructosamine to see if there's any progress. And that's where I learned like the A1C actually is not a really ideal way to measure. And now when I'm hearing like how this range have to be, like there has to be a range and then you don't go up and down, because the average can be, like if you don't have enough checkpoints, the average can be misleading.
It can be, and it's interesting. I should have included the graph of what, for example, a hemoglobin A1C of 7 is, and a patient with little variation compared to a graph of a hemoglobin A1C of 7 with tremendous excursions. It's really eye-opening, and it really helps you to kind of begin to realize the importance of then looking at time in range.
Yeah.
And, when you think about, to break it down for a patient, what we typically say is that when your blood sugar is high, the glucose molecules will attach to your red blood cells.
Mm-hmm.
So it kind of makes your blood cell, instead of kind of being slightly concave, kind of chunky. And then what happens is it gets hung up in your vessels, in your tiny little vasculature. And that's where it causes damage. It's where the neuropathy comes from, the retinopathy. So if we can minimize, the glucose attaching
Mm-hmm.
to your hemoglobin and keep the vasculature system healthy, it's going to improve outcomes. But I would love to even just talk with you, if your patients for bariatric surgery are on mealtime insulin, or even if they're not, I'd love to sit with you for a few minutes and give you some great diagrams and stuff to help you.
So that would be really helpful. I'll tell you, I do daily case conferences for the bariatric program. And now, Amy, we started in the ACO with our ACO nurses. We have, as you know, we do the case reviews all the time, but in the discipline that we have in the bariatric program, we have case conferences now with our nurses. And it's going to be every day in the next couple of weeks. Right now, we are just trying to kind of set up certain things in place, and we do twice a week so far. And I did one today, and for us to be able to look at the patient while the patient is not actually with us, we don't have the pressure of all the other stuff. And then when someone is presenting, okay, here's are the issues that we see while there's, when the last A1C was done, what's the difference between the first and the last time we had the A1C? How frequently they do the monitoring? And there's so much work that needs to be completed. But when I'm actually, while I was listening, as much as I would say there's so much to do, too much to do, with the right way to monitor these things can be easily managed.
Mhm.
That, your point is exactly dead on. And when you look at diabetes as a whole, and, sometimes I forget as a healthcare clinician, it's easy for me to say, well, I want you to count your carbs, and I want you to get your insulin in 20 minutes early, and I want you to check your blood sugar, and I want you to check your postprandial. You forget what I forget what that actually looks like to a patient. And I have stepped back, I've wore CGM systems, I've done finger sticks. And now when I give guidance as to, can you check 6 or 8 times a day for me? It has way more meaning. The burden of the disease. When I hear healthcare providers talk about, oh, well, I have a non-compliant patient, I like to step back and say, what's the hurdle? It's not a non-compliant patient. How can we assist on getting that patient to become compliant? It's a lot.
I think when it becomes so difficult or cumbersome for a patient to really follow and do so many different things, then yes, it's going to be non-compliant because they will give up at some point. But if it's something that, for those who are listening to us, this is my second time that I meet with us. That's online, right? So we never met in person.
No.
Amy's part of our program, but with you, this is our second time. We didn't rehearse this, or we didn't plan to talk about this in this way, other than your PowerPoint. My contribution to this is sometimes with my slow questions, I would say, but really some of them are kind of eye-opening. It helped me to connect the dots between, okay, here's why we are trying so hard, or it becomes so difficult for patients to really manage these issues. But this, it seems like this remote monitoring, continuous monitoring is the way to really help those patients. And my mom has diabetes, and I'm a little bit more sensitive to the diabetes, and she had difficulties in her life to manage that. But now like as you said, every time you say no finger stick, she is a little bit particular when it comes to that, and she never wants to do it, and it becomes so difficult to monitor. So it does really help a lot. I mean, I personally learned a lot from what you presented, and thank you for putting this together for us.
Oh, I thank you so very much. It's if I could add on real quick, one other final thing. Over the last 16 years, when CGM became available, it was sort of a treatment option that was offered down the road. And it's been a tremendous joy to watch hospital systems and doctors go from, we'll get them checking finger sticks and managing insulin to now looking at, you were just diagnosed with diabetes, you need insulin, let's put you on a CGM now. So the relevance and importance of this has really shifted. Insurance coverage has improved tremendously, and we're now giving our patients the tools to succeed.
Yeah, I mean, for something like this, because it's going to be, even the insurance doesn't, I don't know what the insurance coverage is for this, but even if it doesn't, for patients to actually really get a good control on what they are going to go through, because if you have any hospitalization, just one day in the hospital average is $3,000, right? So, and if you have any copay or co-insurance, or if you, I always dramatize this a little bit more with the Medicare patient, but it becomes more and more reality these days. Patient who's 77, Medicare, no secondary, that patient is going to pay 20% of the services. And if they were in the hospital because they couldn't manage their diabetes, that can be a lot costlier than actually investing in this. And, I'll make sure that in our ACO provider meetings, we can also provide more education for everyone and make it more available for our patients as well.
Great, thank you.
Great.
And thank you for having me.
Celeste, I have a question.
Oh yeah,
Sorry.
because we still have a couple more slides.
Yeah, we have my slides.
Yes.
Sorry, Amy.
I know. No, this is good. It's really good because I really want everybody to get a CGM. But a smart pen, I don't know what a smart pen is. Is this the wave of the future? Or do they exist now?
It is. So smart pens have been available for, I guess, about a year now. There's a company called Companion Medical, and their smart pen is called the InPen.
Okay.
And Bigfoot Medical is soon to release theirs that I believe is going to be able to use any type of insulin cartridge. The cool thing about these smart pens is that much like an insulin pen, an insulin pump, they can be programmed with insulin to carb ratio. They can be programmed with active insulin time.
Wow.
And they can be downloadable. So, you can see, your patient with an A1C of 14% that swears they've never missed an insulin dose. This is very telling, how we're doing with timing of insulin, etc.
So it will adjust. You can hook it up to the CGM, so it will adjust the dose based on the blood sugar.
So yes. So it'll be programmed. You still have to tell the pen the number of carbs you're going to eat,
but
it will calculate a correction dose as well as food coverage.
That is amazing. And are these covered by insurance? Do you know?
From what I understand, they are. Now, I can't speak to our geography or Medicare. I don't know any of the specifics, but they are becoming more and more available and utilized.
Well, I'm glad you spoke about that. Thank you. I do want to add something I learned recently about insurance. So we know for the CGM that it is covered generally, like you said, you have to be on multiple shots per day. But I learned that the Freestyle, the Libre 1, not the new one, the 2, the 1 is now being covered by many commercial insurance companies without multiple shots per day for some people who are not on insulin. So I heard from Dr. Hundel's office that, because I just had a patient on it, that you should call your insurance company to see if they'll cover it. because I was so excited. I said, oh, you're not going to get that. You're not on insulin.
Yeah,
It was
yeah.
covered.
So I can tell you that that is the goal. I mean, when you look at the ADA now declaring that it's standard of care,
Mhm.
we are really, really trying to get the insurance companies to approve it, even if you're not on mealtime insulin.
Mhm.
Because let's face it, even if you're on oral agents for diabetes, there is a benefit, and that benefit
Mhm.
outweighs the risk to the insurance company.
It does. There's, one of the things that I think, Celeste, that you were going there, maybe at least that's what I heard. I think the big problem, what I'm hearing, especially when we discuss the insurance coverage, well, why do we need to wait for patients to be really sick to provide this when we can actually have this on and then not to get to that point? Unfortunately, it's not just limited with the diabetes, again, because bariatric is in my day-to-day schedule. So, patient with, if your BMI is 34.7, you are not qualified for bariatric surgery. But if you are 35 and you have this disease or that disease, you are. So, but then what we know is every patient who's at that BMI level, they increase from there. There's almost very little exception. And 95% of the patients are gaining weight. So it's like with this one, if it's not managed, if the diabetes is not managed early on, it just becomes worse.
You are dead on with your points there. And, you don't want to add CGM when you already have nephropathy or, this should be part of our daily management early on as a preventative tool.
Absolutely.
That's a very good point.
So no, this is a lot of good information, and we'll be able to put some pressure on our insurance companies. If there is any coverage issue, we'll make sure that it's better understood, because for them, if they are insuring, that means they're risking, right? So they want these patients to manage early on. You don't want things to go out of control. If we are able to get these ahead of time and proactively approach them, it's much easier than managing, let's say, 7.7 A1C versus 12 A1C 12, right? Bringing 12 to the control range versus the 8 to the control range. The time, effort, everything is going to be a lot different. So, I personally learned a lot from this session. Again, thank you. So, Amy, I will open your session.
I know, I'm going to be sort of a letdown after all this CGM.
No, you are
I'm going to try to make this very important, though, because it is.
No, we learn all the time, remember. The whole issue is, the idea is learning a lot, so every time.
All right. So we're gonna switch to a different type of counting. And what is carb counting? And this goes right in what Celeste was talking about. That if you, one of my biggest pet peeves with people on insulin is that they don't check their blood sugar before they eat, which is what Celeste is talking about. It's a pain to check your blood sugar. It hurts. When I'm teaching my new onset class, when I used to teach in person, and we would do the meter week, I would check all week, and it really, my fingers would be so sore. So I could really sympathize. So again, the importance of the CGM to do it. So if you are not checking your sugar before you eat, well, then and you still take your same dose of insulin, what if your blood sugar is 80? You might go low. What if your blood sugar is 400? You need more insulin. And carb counting goes along with that, because do you need the same dose of insulin? Let's say you normally take 5 units and you're going to eat 30 grams of carbohydrate. Do you still take the same amount of insulin if you're going to eat 80 grams of carbohydrate? You probably do if you're on a set dose of insulin, but you're not going to have the same blood sugar if you eat that big of a difference of carbohydrates. And this goes to people who are on medication also. So carb counting, it is another chore we're asking you to do. But your phone, labels, a lot of it can do the work for you. So it is carb counting. Oh, can we go back? I'm sorry. I wasn't ready. Do you want me to do it? You want me to change the slide?
It's okay because it's only 5 slides.
Oh, sorry.
Oh, if you're able to do it, oh, hold on. Yes, go ahead.
Okay. All right. So carb counting means counting how many grams of carbs you eat per meal. So you're not counting the grams, the sugar, the fiber. You're not looking at starch. You're not looking at other. You're looking at total carbohydrates. Some people think, oh, I can't have sugar. But remember, starch, like potatoes, rice, pasta, all of that is going to raise blood sugar. So you need to look at the total. Paying attention means you can eat a more consistent amount of carbs per meal. So many patients come in on this, say my blood sugars, they just fluctuate. They're not high all the time. You know, I don't have a lot of lows, but they're up and down, up and down. And then I look at their food and they'll say, well, you know, I always eat a protein and carb, they're balanced. But then we look more carefully, and some days they eat a little bit of pasta, but then the other days they might eat a lot of pasta. So there's a very big difference there between our serving size. But if they're counting their carbs and measuring, then they're going to know. If you take insulin with meals, you're able to see, do I adjust my insulin based on how many carbs? And that's something that I really like to move people towards who are using rapid acting insulin. Let's look at a carb to insulin ratio. So rather than taking a set dose, because if you're eating a salad, you don't need as much insulin as if you're eating a giant bowl of pasta. So adjusting for how much you're eating, and then also adding in insulin for based on what your blood sugar is. If you're on metformin, if you're on a GLP-1, if you're on Jardiance, whatever it is that you're on, so you might not have to adjust your insulin. But if you're still taking that same 500 metformin at breakfast and dinner, but you're eating a little bit of carb at breakfast and a big amount of carb at dinner, how is that 500 milligram of metformin going to be the same? And then based on the carbs that you're eating, if you are on insulin, you can work to adjust. Diabetes and blood sugar really likes consistency. So it likes having regular meals. Diabetes blood sugar does not like for me to get up and not eat until 2 o'clock and then eat at 5, and then the next day eat at 8, and then 9 and 10 and 2. So it likes regular meals. You don't have to be, I eat at 8 a.m. on the dot, and then I eat at 10:05. But it does like consistency. So it's important. All right, so I requested control, and now.
Yeah, I did.
And you gave it to me. I lost my arrows. There they are. Okay. Okay, so how to do it. So read the label. And I have some examples in the next one. So here we have some pasta, and we're going to look, I have some labels that you can see better, but we're going to start with reading the label. And the next slide, there's an example. You want to really look at the serving size. So again, we'll go back to those bowls. I can look at the label and I can see that 2/3 cup is 41 grams of carb, but if I eat this or this, it doesn't really matter what the 2/3 cup is. So I need to measure how much I'm eating. And then I want to look for total carb. And if you eat more than that, I want to adjust. So if 1 cup of cereal is 20 and I'm eating double that, then I need to count double that. So practice. So if we look at this, 1 cup of carbohydrate, or I'm sorry, 1 cup of this macaroni and cheese is 31 grams of carb. So there I know right there. Okay, so this is 31 grams. So my dietitian said I can have between 30 and 45. So can I have 2 servings of this? Well, that would be 62. So that may be too much for you. Now, she did say on special occasions I could go a little bit over. Maybe I should go for a walk. Maybe I need extra insulin with this. Should I eat 3 servings of this? That's a lot of carbs. So let's say I eat my macaroni and cheese. I eat 1 cup because that's all I'm supposed to have with 31 grams. But then I decide to have one of those really delicious rolls with it. And I look that up, and that's 20 grams. So now I'm up to 51. And then I decide to have some dessert at 25 grams. So I've got to add all these carbs together. So now my carbs are really high, but all I have was a roll and some mac and cheese and a little tiny scoop of ice cream. How did I get almost to 100? Because they all add up. But if you're not paying attention, looking at your labels, counting your carbs, you don't necessarily know. And if the next day you eat all that and you're, oh, my blood sugar is high. And then the next day you think, oh, I got to do better. So I'm just going to have mac and cheese. I'm not going to have my roll and my ice cream. And then I take the same amount of medicine, but then I have a lower blood sugar. Why is my blood sugar so crazy? Because some days I'm eating a lot of carbs and some days I'm eating a little bit of carb. So what if there's no label? What if you want to count that roll and it came in a bag from the bakery and there's no label on it? If you have your phone, you can Google it, a bakery roll. There's apps like MyFitnessPal, which have everything in them. You can look at that. If you're worried about the accuracy, because sometimes it's not right, check more than one source. You know, what are some rolls? Let me take an average. Ask your dietitian for a carb counting book, because we have them. You can purchase them. So Calorie King is one we used to give out years ago. Celeste remembers that one. So it's this little book. It has a large print size that people carry. And so it has carbs, and it's, even though they make a new one every year, I still have one from 2008. It's pretty accurate. And then I really like Glucose Buddy. So Glucose Buddy is an app that you can put your carbs in, and you can also put in what's your blood sugar, and you can put in how much insulin you gave, and then you can share the app with your provider so they can see, all right, this is what I'm doing. Because if you're, and Celeste can speak to this, if your healthcare provider is looking just at blood sugars, but they don't know how much insulin you took and they don't know how much you ate, they only have one piece of the puzzle. But if then I have to say, oh, well, you're eating 300 grams at lunch every day, well, that's why your blood sugar is high. Or and you're not covering the high that you went in with that, well, that's why you're high. So having all that information. Now, I do believe that the free Glucose Buddy you cannot share. I think you do have to pay, I think it's $5 to pay for the premium, which you can share. All right, so what about fiber? What about sugar? What about those other types? Sometimes there actually is other carbohydrate that you want to look at. What do you do with those? So those add to your knowledge. When you're counting carbs, you're not counting those. Now, if there is more than 5 grams of fiber, and we talked about this in a previous webinar, you can subtract half the fiber. If we look at this, there's only 4 grams, so we can't subtract. But if I look at this, why are we talking about this if I don't have to count it? Because it's good information. So if I look at this label, I can see this has 4 grams of fiber and it has 12 grams of sugar, which 10 of those are added sugar. So this has a lot of sugar. So this is not the healthiest option. Fiber is obviously a good thing. So if something has a lot of fiber and not a lot of sugar, that's going to be a healthier choice. So this can guide my decision. Just like if you're looking at weight loss, the calories are going to guide your decision, but we're not necessarily counting them. The protein is going to guide your decision. If you have high blood pressure, I can look at this and I can say, oh, it's only 160 milligrams of sodium. It's good. Whereas something else, oh, that's 580. I can't have that. So if I look at this pasta, which is red lentil pasta, and I look at this pasta, which is just plain old white pasta, and then I look at this one, the whole wheat rotini, they're all about the same amount of carbs. They're all pasta, but I can see that my whole wheat one has 6 grams of fiber, and then I can see my lentil one has 6 grams of fiber, and I can see that my white one has 2 grams, so that one's out. And then I can see, all right, well, which one do I like better? That might be part of it. This one's a little bit lower in carbs. So if I want to eat more of this one, that might be my better option if I really like to eat it. And I can say, oh, this is 13 grams of protein. That's pretty good. Or you might say, well, Amy, I hate lentils. I don't want to eat that one. So I'm going to go with this one. So using that different information on there, although if you haven't tried this one, I'll say try it. It doesn't taste like lentils. My child doesn't know he's eating lentils when I give it to him. But the black bean one it looks like it's black. So that is, you can't fool people with that one. So that one looks like pasta though, if you try that one. So which label is better? Let's take a little test. So we're looking at both of these. This is cereal. So you can see the serving is 1 1/4 cup. And you can see one of them is 48 grams of carbohydrate and 1 1/4 cup. And one of them is 40 grams of carbohydrate. One of them, so the one on the left, it's 48, it's 9 grams of fiber. And it tells you the soluble and insoluble. 20 grams of total sugar, 9 of those are added. Do either one of you have a guess why there might be natural sugar? What kind of cereal this is that has natural sugar in it?
I don't do cereal.
He's like, I don't eat that. Celeste, any ideas?
My first thought is there dried fruit in it?
Ding, ding, you're correct. It's Raisin Bran. So people often think that, oh, I'm eating Raisin Bran. It's so healthy. It's bran. Bran, yes, the bran is really, really good. It's the Raisin Bran. And especially if it's Kellogg's, which is sugar-coated raisins. So you have, that's why we have the total sugar being 20. So when you have a natural sugar, it is going to add sugar, but we're more, because natural sugar is not always a bad thing. If an apple had a label, it would have natural sugar in it. But this is a lot of sugar and it's a lot of added sugar. So then if we go to the other one, it's 40 grams of carb, it's 13 grams of fiber. And it still has sugar. It's 8 grams of sugar. Most of them are added because that one is not Raisin Bran, it's Kashi. So you can see that one still has sugar, but it's less sugar. So the one that's better would be the one on the right. That also has 12 grams of protein. So if you think about it, it's going to balance your blood sugar better. You've got more fiber and more protein. So, and there's a lot of different things that you can use on a label. So if I'm somebody who's watching, as I talked about blood pressure earlier, I want to look at sodium. The Raisin Bran, we don't think of Raisin Bran as salty, but it's 200 milligrams of sodium. And what if you eat more than 1 1/4 cup? And milk has sodium in it too. So it, even though it's not salty, still has some sodium. So they add up. Let's say I have issues with my GI system, with my stomach. I want to look at that fiber. Am I not supposed to eat a lot of insoluble fiber from my doctor? Well, maybe I shouldn't be eating the Kashi. So paying attention to those. If I'm on a low potassium diet, they both have potassium in it. So you can learn a lot from a label. I mean, the point of this is really carb counting to get an idea. And if you're not looking at carbs now, the first thing I tell people is just start looking. Start looking at the labels and getting an idea. And it seems really awful. Like, oh, there's so much work. I have to look and I have to measure. But the more you do it, the more that you know. So when I worked with Celeste in pediatrics, I knew every food that kids eat. I could rattle off all of the carbs. A cup of Cheerios was 20 and a half packet of ramen was this, and a cup of macaroni, Kraft macaroni and cheese was this. I knew them all. And you will know because you know all the same foods that you eat every day. So just like Celeste talked about CGM as having that vital piece of information, this is that vital piece of information that's going to keep you steady. Because again, if I'm eating, I just had a bowl of cereal, but I had that 48-gram carb bowl of cereal and I had a big bowl. You're talking about possibly 96 grams of carbohydrate, and that's without milk. So we don't think of a big bowl of cereal as necessarily giving me really high blood sugar, but if it's over 100 grams of carb, it absolutely could. And was that
Amy, can I add on to something there?
Yeah, please.
The serving size for me, I think is huge and very important. And especially if we're looking at weight loss, perhaps, I know with my son, who does have type 1 diabetes, he would have Oreos and milk every night. And I had a measuring cup that sat by the fridge. So we knew that, a cup of milk was 12 grams of carbs. And if he did not measure it in that measuring cup, that cup of milk then slowly grew to the point where it was nearly 2 cups of milk. So, to really hone in on what is a normal serving size and not just eyeball it, I think is really important.
Yeah, no, I'm glad that you said that because they have changed the serving sizes. So like Cheerios, I had to relearn, like Cheerios, they said was 20 in a cup, but now the serving size is 1.5 cups. But still, if you look at, I didn't bring down the right bowl. So the average cereal bowl in most households holds 2 cups of cereal.
How about that?
Look at that giant cup right there. So
yes.
It's your phone.
It's not the biggest one, so it's the middle size.
And you're right, 1 cup, 8 ounces, which I had one here. Unfortunately, I don't have it at the ready. 8 ounces is very small. Nobody has that size cup. I mean, we talk about like you only need 4 ounces of juice to raise your blood sugar. Who has 4 ounce juice glasses? Nobody. Maybe somebody's grandmother, right? I mean, your average glass is like this. This is a cup. nobody really eats cereal in this little size bowl.
Oh, that's little.
This is 1 cup. Yeah. So it looks like an ice cream bowl, which a cup of ice cream is not a serving of ice cream either. This is more typically a pasta bowl. This holds 3.5 cups. But people.
That looks like my husband's cereal bowl.
Yeah. So if you think about it,
But it's
if you're
1 cup.
eating that, think about the carbs. So I like to eat salad out of this, but I recommend. But you're right. So measuring, even though it is an extra step, it's really, really important. And you can get measuring cups at the dollar store. Multiple sets of them.
So just wanted to have one final, warning. Everything that's coming from the background, that's coming from my puppy, and he's right next to me. So I hope people don't think that I'm making those sounds. So, this was a lot of good stuff. And I do appreciate the time. I don't know if you guys have any closing comments, but I think in fact, the other day, I was talking to our nurses, and one of the, learning resources or sources, what we can give it to the patient. We are sending these video links. I think it's important for them to spend the time and listen to these sessions, because each of them have a lot of learning. Each of them has a lot of learning points, and some of them we may need to hear more than once. We try to make this as more interactive as possible, and hopefully it's getting to the right people's homes. And I do appreciate for the time and the effort from you guys. If you have any last minute comments, I'll take those.
Celeste, do you have anything before I talk about our next one?
I think the only thing that I would like to convey to, the participants, our patients, is, talk to your healthcare provider. There's lots of tools out there. We really want to make this burden less for you, and we want you to succeed. So, we wish you all the best, and we're here to help you.
Celeste, thank you.
Thank you.
Celeste, thank you so much.
Oh, you're welcome. My pleasure.
Appreciate your
Thank you both. Guys, thank you so much again. Have a good evening, and we'll see you in 2 weeks.
That's our next one is June 23rd with Katie Callahan. We're going to be
Am
talking
I doing the garden? Is that the garden session?
No, that is July 14th. We will be,
so I'm
we
still
will be
taking
in
a lot
your
of.
house, so be prepared.
Okay, so
You're
I'm taking pictures as the yard is. This is little garden happening there.
Oh, wow.
Yeah, it's happening. There's still some more stuff coming out.
So be in your garden and your pantry and your refrigerator. So be
all right, great. I'll do some shopping.
All right, thank you so much.
Thank you.